we see belong to that category. And definitely MS Visa is going to throw more light into that, and we are going to benefit from this lecture. And again, a warm welcome and many thanks to my dear Nikhil for having made arrangement for this meeting. Since this is a first meeting, there are a few technical glitches, and I hope in coming meetings we will be able to overcome it and we will have a smooth run. And over to Viswanathan, sir, please.
Okay, thank you. Okay, good evening all, and thank you, Dr. Venkat, for inviting me. And I know some of my friends are there, and I'll start. I think the reason for me choosing this topic, this was one of the common problem I encounter, and also this is a common problem I get referral from pediatricians. So let me go to that. Actually, ideally, when it's physical, no, I usually interact with the audiences because there are a lot of questions I throw, and then I hear, then I go through. But the thing is, but I'll try, even online, I would like to see whether we can have some sort of interaction, because I would rather like an interaction, and so it becomes much more useful for you. I'm currently based in Apollo Children's, Chennai. Okay, this is where I trained. I did my MD Pediatric from Chennai. Then I did my overseas training in Birmingham and London King's College and Great Ormond Street for Children. And I've been back here for the last 12 years in Apollo, actually. And so basically, I'll be giving a bit of an outline and a little bit of terminologies, because you need to know the terminologies, when to use what. And then I give a little bit of alarm signals. And I will just go through how to evaluate and diagnose. I'll give briefly. See, there are people who have to admit, it looks like. It says is admit. Okay, let me see. Dr. Nikhil, can you admit the participants? Okay, thank you. If you admit, it's fine. So then, and then a little bit of functional GI disorders. And then I'll talk about management, and particularly I'll be concentrating on safe case scenarios. Okay, as I mentioned, it's one of the very common problem worldwide. Though they may not have mortality, significant morbidity, and because of missed school days. And not only that, because of the children are having so much of issues, the parents actually have to put leave and whatever the job they may be. So it's actually, and also the high users of health resources, particularly in world where the government is funding, they have this economic data. And then the most problem is people do get confusion between the functional and organic disorders. And there are also, as I mentioned, there's a diagnostic uncertainty. And so I just want to say you can use the word chronic abdominal pain, any pain lasting 2 months, whether it is intermittent or constant. Previously, it used to be 3 months. Now, if it's just 2 months, at least it's more than enough. In fact, practically, I would use the word even if it is more than 4 weeks, because acute is not going to last more than 2 weeks, actually. Even if it is lasting more than a month, for practical purposes, I will say chronic abdominal pain. But for academic purposes, it is more than 2 months, whether it is organic or functional. So the functional abdominal pain, and it's basically any pain that occurs in the absence of, there is no any identifiable or anatomic, biochemical, metabolic, and inflammatory disorders. And that's what people say that. But now I'll talk to you about that. A recurrent abdominal pain were used in the past. And I just want to ask you, Dr. Nikhil, can you allow the participants who's waiting in the wait room? Is it okay? Can you just tell me whether you can do that or whether I have to do that? Can you hear me?
I think they can unmute themselves, sir.
No. There are some says they're waiting to enter the room. They're in the wait room.
Sir, I don't find anyone in the waiting room, sir.
Okay, because then I have to admit them. Okay, fine, no worries. And so basically, the recurrent abdominal pain is a term initially used by Apley. This was basically 1950s. Basically, he's the person who coined the word recurrent abdominal pain. In a pain lasting more than 3 or more episodes of pain, severe enough to interrupt child's activities, and occurring during a period longer than 3 months. Actually, nowadays, we don't use this word for diagnostic terminologies. However, you can use this word to describe the type of pain, but it's no more a diagnostic terminology. The diagnostic terminology is chronic abdominal pain or acute abdominal pain. Chronic abdominal pain, you can classify them as organic, around approximately 20%. Functional, around 80%. Just be very careful. When I mean functional, it is not psychogenic. It is not synonymous with psychogenic. Psychogenic is totally a different thing. It's basically they need a psychiatric input. When I mean functional, it is a positive diagnosis. I will talk to you in detail about that. And basically, it is itself as a different terminology. 1 second, I had unmute this person. There are two waiting. Yeah. Okay, I admitted them. Okay, fine. So, so functional itself is a positive diagnosis. I will discuss that in detail. So etiology, I will say, I want you to remember like this. You know, your GIT starts from lip, actually from lip to anus. So anything, you know, you can start with even recurrent mouth ulcer. I'm just talking about that. Gastroesophageal reflux disease you have there. Then you can a bit of gastritis or duodenitis or duodenal ulcer or expiatory infection. Then you go lower down, you can have a bit of an intolerance, malabsorption. It could be, you know, dietary intolerance, or it could be, you know, wheat intolerance to celiac disease. If you go lower down, you have the infections, very common in our country still. And then you have the IBD. Then don't forget chronic constipation and chronic appendicitis can cause sometimes abdominal pain, and not to miss the anatomical abnormalities. And nowadays, more and more, we find motility disorders. But then you need to remember the functional GI disorders also. I'm going to discuss that a little more in detail. And then not to forget the organs in your abdominal quadrants, not to forget the liver, hepatitis, or gallbladder colic, or acute recurrent pancreatitis, or chronic pancreatitis. Or urological, it could be UTI, or urinary calculi, or polyuretic junction obstruction. Or one need to think about in young teenage girls, please don't miss the pelvic inflammatory disorders. 1 second, I have to admit this person also. And not to miss the ovarian cyst. And as I mentioned earlier, we have a separate psychosocial cause. And the earlier word of Munchausen by proxy, that terminology is replaced by factitious illness or fabricated illness or induced illness. The earlier terminologies, Munchausen by proxy, is replaced by this terminology. So you need to know that. An important thing, just because somebody is having functional abdominal pain does not mean they don't have an organic etiology. Or even if you have a diagnosis like, you know, celiac disease or IBD, they can also have an associated functional abdominal pain. So what I'm trying to say is they can coexist. So basically, how do you approach? It's basically detailed history and examination. And investigations, you can do so many under the sun, but you need to be very, very focused and specific, you know, so that you reach a diagnosis in shorter span of time, and also not to make patients spend too much of money. And then, of course, you need to manage the patient according to what you find. So basically, the first thing will be you have to differentiate the organic from functional abdominal pain. You identify the site of pain, and then identify the predominant symptom associated pain, or if it is also isolated periumbilical pain. And then depending upon the site, depending upon the predominant symptom, depending upon the presence or absence of the alarm signals, you arrive at a provisional diagnosis. So you all know this is basically, you know, teaching in your undergraduate PGs. You know, when you have a pain which is localized and consistent, and it lasts longer, or it is well defined, it has to well defined. And then nocturnal, I will not say just because the pain is nocturnal does not mean it is organic. But however, if it constantly wakes the child from the sleep, yes, then you can consider that likely to be an organic cause there. And then the functional one, you can have periumbilical, epigastric, and lower abdominal pain. And then it is usually paroxysmal. It comes for a few seconds, few minutes, and clusters, and then disappears. Child will be fine after a few days or after even a day. As I mentioned, there is not a specific set of pain. It's dull, it's vague pain, can be diffuse. Usually, they do not affect the sleep, and they may have an associated somatic symptoms like headache, nausea, vomiting, etc. So you all know the quadrants. If it is in the right upper quadrant, hypochondrium, you are talking about hepatobiliary. With the left hypochondrium, we think about splenic, and also not to miss the transverse colon. The splenic flexure is there. It could be even IBD there. And you all know the right iliac fossa very well. The most important thing you need to think about is appendicular pathologist. And not to miss a terminal ileal pathologies, which could be IBD or ileocecal tuberculosis, or it could be a mesothelioma lymphadenitis. But then look at this, the left-hand side, and when I say B is basically lumbar, usually renal cause. But then type 4 left iliac fossa, I'll come to that. Type the 3 is basically suprapubic. Most often it's a bladder or UTI, cystitis, those sort of things. But I want you to think about, when you have a pain in the left iliac fossa or suprapubic, this could be a child who is having chronic constipation and fecal impaction, and then that is the reason why the pain is there. So don't miss that one. And always I tell people, always I tell people, for me, it's not 10 quadrants. Actually, it is 12 quadrants for me. 9 abdomen, then you go to the genitalia and groin, that is 10th for me. And perianal region, don't miss the perianal region. Just finding a tag and fistula helps us a lot. And importantly, though I'm saying this on 12th, I will not never miss the oral cavity examination. Don't miss the oral cavity. Those is part of a general examination, but also keep remembering that whether you've seen it or not, even after looking at the abdomen, just again look at the oral cavity. So usually the epigastric, what you have symptoms-wise is dyspepsia. It could be bloating, it can be flatulence or indigestion, or it could be early satiety. Anything can come under the umbrella of dyspepsia. Periumbilical is isolated pain and there is no specific character. And it's usually functional. Lower abdominal pain, which could be in suprapubic or left iliac fossa, right iliac fossa, it could be an altered bowel habits. As I mentioned, it could be an constipation, or it could be diarrhea, or it could be, sometimes they may associate colitis, and IBD. They usually have blood and mucus in the stool. So when you have a child with epigastric pain with dyspepsia, it's again, here, the chances of the child having an organic problem is slightly higher compared to a child who is having an isolated perumbilical pain. So here you could have epigastric, that. They can have a reflux disease, they can have pyloric disease, H. pylori, or they could have pancreatitis, which radiates to the back, or you could have a biliary disease. Sometimes biliary disease, say right type of, it can be an epigastric also. Sometimes giardiasis or carbohydrate malabsorption. But again, here you have to think about functional. Again, you have to think about dyspepsia, pain on eating, and aerophagia. Aerophagia is one important one you should not forget. You have to ask the child whether he's swallowing a lot of air, all sort of things. Periumbilical paroxysmal pain, I mentioned earlier, it's much more functional. It's around 90% is functional. And here it could be the abdominal migraine also can present like this. However, sometimes anatomical issues like malrotation or adhesions following previous surgery or food intolerance can have periumbilical pain. One need to remember that. Lower abdominal pain with altered habits, altered bowel habits. Again, you have a chance of organic slightly higher here. You could have an IBD, or you could have a tuberculous abdomen. And again, a little bit of food allergies, non-specific, they can present like that, and carbohydrate malabsorption. So, functional again here, it can be about IBS, functional constipation, don't miss it. So, what I'm coming to you now here is alarm signals. I mentioned here the site I told you. I told what sort of symptoms can be there. And let us look at the red flags. The red flags, symptoms, which have to look at age less than 5 years. Usually, they have it, most likely you need to take a little bit, serious to evaluate it. And especially if they have a significant weight loss. When I mean weight loss, it should be involuntary. Nowadays, lot of teenage girls and to some extent boys do go for a voluntary weight loss, and that is not as significant. And of course, growth issues, not to forget any hematemesis or melena, or as I mentioned, severe diarrhea, blood or mucus in the stools, any bilious vomiting. When I mean bilious vomiting, it's not yellow vomit, it's green vomit. So any green vomit is significant. And then we are thinking about urinary symptoms. We need to think about, persistent unexplained fever. And you have to think about arthritis, rash. When all those things are there, they could point towards an underlying inflammatory process like IBD. And then family history is also very important. When I say alarm symptoms, you have to ask the history. Make sure there's a family history of IBD. Particularly ask history of pancreatitis and pancreatic cancer in the family. And celiac disease, of course, particularly people from northern part of India and western part of India, wanting to look into that. Alarm signs, again, don't miss a growth failure. That's very important. The most important thing I will ask my patient is the weight. That has to be there before the patient enter my room. Then only get an idea how to evaluate this patient. And then delayed puberty, of course, in IBD. And then you look at the jaundice, you look at for pallor. That gives us a clue what's going on. Of course, tenderness and abdominal distension. Abdominal distension, you think about malabsorption, but it can also be a part of liver disease. It can be part of a food allergies also, carbohydrate malabsorption. And the other thing is, obviously hepatomegaly or splenomegaly, perianal disease. I just want to highlight this again and again. Perianal disease, very important. Please look for that. I had recently had a boy came from Andhra Pradesh. He was being treated as 6 months of ATT. But there was absolutely no improvement with this patient. The patient came with my retail examination. I was just looking at the perianal area. Loads and loads of tags and fistulas. Usually, now I will say even 99% tuberculous abdomen will not present like that. And the child was not improving even after 4 or 6 weeks or 8 weeks of tuberculous treatment. You need to think about what is going on with this patient. This patient simply had Crohn's disease. I have to do an endoscopy and colonoscopy with severe florid Crohn's. So that's what I'm telling. Just look at it. You don't have to do a digital examination. Just look at the perianal area as part of an abdominal examination. Apart from looking at genitalia and groin, it's very important. And of course, look at any joint issues. And I mentioned earlier, oral disease. Sometimes Crohn's disease present exclusively with oral disease. I had a dentist who referred to me a child with significant buccal mucosal swelling and also lip swelling. He couldn't find any dental cause. He asked me, can you have a look at it? I had a look at it. Look, this could be a Crohn's. I did an upper GI endoscopy and lower GI endoscopy. There was a lot of findings in upper GI. This turned out to be actually a Crohn's disease. So you need to remember that also. A little bit of few words about functional GI disease. Basically, we had many criteria, and just basically it's a combination of factors like visceral hyperalgesia, abnormal bowel activity, abnormal gut motility. Basically, what it does is when there is a predisposing factor like stress, gut distension, inflammatory process, or sensitization, something else. These factors interact and they result in the abdominal pain. So when important thing is, there are many criteria. This is the latest Rome 4 criteria, which is published in 2016. And this is basically a foundation in Rome. They extensively look at functional GI disorders. And under section H2 is basically childhood functional abdominal pain disorders are discussed in details. They include a lot, but I'm not going to talk about anything about H1 here. I'll be talking about H2 here, which is functional abdominal pain disorders, functional dyspepsia, post-menstrual distress syndrome, epigastric pain syndrome, irritable bowel, abdominal migraine. Anything not fitting with this will come under functional abdominal pain, not otherwise specified. So basically, any pain which is in the epigastric area, and if there's an associated dyspeptic symptoms, I mentioned dyspepsia, what it means earlier, and if it's there at least for 2 months, and there is no association with defecation, and nowadays you don't have to go and look for an anatomical or inflammatory causes. As long as clinically you are convinced, you can diagnose as functional dyspepsia. Remember an important thing. All functional GI disorder diagnosis is a positive diagnosis. It is not a psychological diagnosis. So you are very welcome to do that, provided there is no any underlying alarm signals. And then as long as you do that, it's absolutely fine. Okay? You are allowed to make a diagnosis so that you don't evaluate them too much. Irritable bowel syndrome, again, pain lasting once a week for 2 months. But here, the pain is associated with something to do with defecation. At least 25% of the pain, at the time, there is an onset with the change in the frequency of the stool or the form of the stool. So the pain sometimes gets better after passing stools. And again, there is, as long as you're clinically convinced, it's fine. So abdominal migraine is not a common diagnosis, but you need to know this one. Here, there's a paroxysmal episode of intense acute periumbilical pain that can last even for an hour. But then they will be fine in between. They'll be absolutely fine. But they cannot associate the symptoms like somatic symptoms like anorexia, headache, nausea, photophobia, vomiting, pallor, as we find, in a basic neurological migraine. And then you have to have at least 2 or more times in the preceding 12 months to make a diagnosis of abdominal migraine. If there is a pain which is lasting for 2 months, but you are unable to fit in with functional dyspepsia or with irritable bowel syndrome or with abdominal migraine, then you can classify them as still as functional abdominal pain. NYS is not otherwise specified. So these are the 4 things you need to remember. Whenever there's a functional abdominal pain, don't talk only to children, talk to the parents in detail. What they need to tell us is actually, we need to assess the parents also, both their, mental ability and what sort of stress going on in their office or in the school or whatever. We need to know that. That's very important. And sorry, I have to keep on admitting this new entrance, and there's a reason. Sorry about that. And so we need to look at all those things. I tell you again, I am seeing a lot of functional GI disorders. You look at all those things, you all know about this one. I'm not going to discuss that in detail, but one thing is school absence is very, very important. You need to look at that and particularly ask about one important thing is change in the school or even in the same school. Nowadays, some school within the same, if the child is moving from 6th standard to 7th standard, they are changing the section and children are finding it difficult to adapt to new friends. Even that itself is creating a problem. I remember one of a collector actually saw me, asked a question, what happened? Nothing happened apart from changing the class. I asked the boy, what happened? I'm unable to find any new friends and these people are not at all helping me. So I told them, let's wait for 2 more months. 2 more months waited, it's nothing improving. I asked me, what do you want to do? He simply asked me, can I go back to the previous section? That's it. And then he went to the previous section, whatever he was in, and he was doing very well. He was able to mingle with old friends. He's doing very well. And GI motility, and as I mentioned earlier, about this one. There is a lot of studies nowadays about the neurogastroenterology. This another specialty itself. We look at all those things, and there is a strong association with functional abdominal pain. So before I go, now I want audience to interact. Please unmute people. Sorry, this is gone like this. Okay, sorry. I want to ask people, just one of you say, what are the investigations? Just one you say, please. One, anyone. Just say one investigation and let us move to the next person.
Ultrasonogram abdomen, sir.
Thank you. Very good. Thank you. Anyone else? Anyone else want to do anything?
Peripheral smear.
Very good. Anything else?
Urine
routine, sir.
Very
Urine
good.
routine and
I like
culture.
it. I like when people say urine routine. I really like it. That's one of the non-investigation, easy investigation you do that. I really like it. Anything else?
Serum amylase.
Very good. Very good. Very good. Anything else?
Stool chart.
Stool chart. That's right. I agree with you. Not the stool analysis. Stool chart is much more important. Thank you. Anything else? Somebody told peripheral smear, but what is the basic thing you do before peripheral smear? CBC.
CBC.
What was that one? Anything else? I remember people saying CBC, peripheral smear, ultrasound, urine routine, serum amylase. Anything else they said? I missed
Stool
it.
routine, sir.
Stool routine, you can do that. Okay, I tell you honestly, stool routine, I do that anyhow. But most of the time, this stool routine is seen by the very, very basic technician who has not got any experience at all. Some of these microbiologists who are, they're not very much bothered about stool analysis. And most of the time, the stool routine is normal for me. Anyhow, I think you should do that. Yes, I agree. Anything else?
Stool occult blood, sir.
Very good. I'll talk to you about that. You mentioned that. I'll talk to you about that. Thank you. Anything else? Okay. Fine, you covered that. Complete hemogram, peripheral smear. Don't forget ESR, CRP. Particularly, I'm not insisting to do that. But if you have some symptoms, do that. But my lab, when I ask for CBC, they do CESR automatically. It's not necessarily the case other labs. Also think about LFT, not in every patient, but if you have a icterus or right hypochondrial pain, do consider that. Microscopy is important culture, you may consider that. Fecal occult blood, I just wanted somebody to say that. So what I do is fecal occult blood. If the pain is there and the hemoglobin is stable, I don't do fecal occult blood because again, people have to do it correctly. And second thing, if there is a low hemoglobin and if I can't explain the pain, then I do fecal occult blood. Otherwise, I will not do that. Ultrasound abdomen, consider 4 hours fasting and do that. That will be much more helpful. Screening for TB. Nowadays, I'm doing it less and less. I want you to say, you're all pediatricians practicing for 15, 20, 30, 40 years. I just want to say in the last 5 years only, please, the last 5 years, how many abdominal tuberculosis you have seen and how many tuberculosis in general you have seen in the last 5 years, please. You can share your experience. In the last 5 years, have you seen abdominal tuberculosis or in general any tuberculosis? Anyone? Because
abdomen TB absolutely nil, sir.
very good, thank you. And in general, any tuberculosis, pulmonary tuberculosis, anything like that?
Yes, sir.
CNS tuberculosis on the rise, sir.
One
or
two,
two.
Yeah, maximum in 5 years. Okay, the message I am trying to get across is in the last whatever years I have been here, I am looking for tuberculosis abdomen. I can't find, honestly. What I am trying to say is, one second, somebody's entered this, I have to admit that. What I am trying to say is, nowadays, I see more IBD rather than tuberculosis. I'm not sure. I don't think this is a referral bias because I'm sitting in a tertiary center. But I do think people overdiagnose tuberculosis and they underdiagnose IBD. This is what is my perception. Because I am not seeing tuberculosis being missed, but I am seeing IBD being missed. That's my worry, actually. Okay, we'll come back to that. Now, you all told me about the first line investigations. What are the second line investigations you can do? Which basically you have to refer to me for me to do that. So what are the things you have to ask me to do that? When do you do that? Just tell one by one. The same thing. Because I love interaction, actually. That's the only way I feel that, I'm giving some messages to the audience.
CT abdomen, sir.
CT abdomen. Okay, very good. Okay, we'll come back to that. Thank you. Anything else?
Sir, upper GI scopy and lower GI.
Yes, sir. Thank you. Anything else?
And investigation for H. pylori.
Very good, sir. We'll come back to that. Very good. Very good. You raised that one. Okay, anything else?
Mechel scan, sir.
Very good. Okay, very good. That's organic. Very good. Okay, anything else? Anything else? Just say something. So
Sir,
that
cow protein allergy you have to test, sir.
Yeah, okay, very good. Anything else? Okay, we'll talk to that. No problem. That's fine. We are covered. Yeah, endoscopy is important. When I mean endoscopy, I'm just stressing here, it's upper GI endoscopy and colonoscopy. Colonoscopy does not mean only looking at colon, it also looking at the ileum. And the technique to look at the ileum in children is different from looking in the adults. So it's very important. People refer to pediatric gastroenterologist, not adult, because sometimes they just look at the colon, they forget. They don't bother looking at ileum because in ileum, they may not have findings. But in children, I tell you, 15% to 20% of IBD will have findings only in the ileum and nowhere else. If I don't look at the ileum, if I don't look at the biopsy from ileum, I will miss an IBD. And also, adults, when they look at the colonoscopy for IBD, they just do colonoscopy. They don't look at the upper GI endoscopy. It's very important we do both together in children because IBD, again, 10 to 15% of patients will have findings only in the upper GIT. Yes, only in the upper GIT and nowhere else. So it's very important when the evaluation of IBD, we look at both upper GI and lower GI. And imaging, somebody mentioned about that. Yes, I discussed about that. Very important. We can do that contrast study when you're suspecting malrotation, or you can do CECT, particularly when you are evaluating for pancreatitis, or MRI and chronic pancreatitis. Celiac serology, when you do celiac serology, most of the labs do IgA, TTG, tissue transglutaminase antibodies, or IgG. But it's very important you check the serum IgA also. The serum IgA is low, you can have IgTTJ falsely negative. So it's very important you check IgA also when you check IgA-TTG. The specifics, if Dr. Jalil mentioned, yes, you can check specific IgG to common food allergen, but again, only 20 to 25% is IgG-mediated food allergies. 75 to 80% is non-IG. So if the first test may not say anything, history is more important. Fecal calprotectin, if IBD is suspected, we can do that, but itself is not enough to diagnose disease. You need to have an endoscopy and colonoscopy and biopsy to diagnose it. And pH studies, we can do that. But nowadays, we don't do only pH study. We do what we call as impedance studies, or we got multi-channel, impedance, because we want to look at the alkaline reflex also. And sometimes we do manometry, especially eclasia cardia. We do manometry to find out. And then for small intestinal bacterial hydrogen blood test, Dr. Jalil mentioned about H. pylori. Yes, H. pylori, we can check, we can make a diagnosis of H. pylori infection only on upper GI endoscopy biopsies. The stool for H. pylori or any blood test is not useful. And even if I find a H. pylori on a tissue diagnosis, I will not say an H. pylori disease. It can be just a bystander. There should be an associated duodenitis or gastritis along with H. pylori. Then only I will say it's H. pylori disease. Okay, so treatment, basically, if it's a functional abdominal pain, you are going to explain and reassure. And then, basically, what is important thing, you have to do that in front of parents and with the child in presence. You tell them that the pain the child is having is a real symptom. It is not active. It is not malingering. You tell the pain is the real symptom. However, there is no underlying serious medical problem. You have to tell them the child is growing well, child is doing other things fine. So let us not worry about that. So identify the red flags, as I mentioned earlier. The most important thing I want all you to do is don't give NSAIDs. I hardly have to give it for my patient, unless they have a severe fever, etc., etc. Even them, I can manage them with paracetamol. As a gastroenterologist, the last 12 years in Chennai, I hardly have to use for 1 or 2 patients, nothing more than that. And then, whereas you have not used them at all. And of course, you have to identify the triggers. And most important, avoid the psychological labeling. Even if you're going to refer to psychologist, I tell them like this. I am going to refer to a person who is not a psychiatrist, a psychologist. I am going to ask them to give you some ideas, some how to cope up with their stress. I tell like that, so that they understand. And then I say that, well, you need some more symptoms. I need to give you some more medications. So I need to involve this doctor so that he can advise you properly. So instead of using psychiatrist straight away, okay. And most importantly, we should encourage you to go for normal activity. And that's very important. Yet if they're not going to go for school for more than 1 month, don't ask them to go to school straight away. That is just not possible. You will fail. You ask them to consider going to 1 hour, 2 hours. I will write a letter to the school saying that, please do allow this one. There's nothing wrong in that. Okay. And then most important thing, these things you have to be available for regular follow-up. I have a patient, seeing me 6 months, 6 years now. This patient doesn't have anything, but they want to see me every 2 months, 3 months, just to reassure them and reassure the child every time they come here. But, initially I evaluated, I told there's nothing wrong. Your child is growing well, everything is fine. Nothing need to worry about it. Child is having pain. So what? I done everything. Nothing to worry about that. So that's what I tell them. Okay. Sometimes giving a medicine, you can have a placebo response. Just because they have response does not mean that it's effective. So most important thing I tell you is, please do make use of second opinions, because sometimes I have to spend 30 minutes to 45 minutes just with one patient, which as a pediatrician, you may not be able to do so. So please do involve, because it involves a lot of talking. As you say that, if I'm talking to you like this, you imagine me how much I'm talking to the parents. Unless they want to leave, I will not leave them actually. So because that's how it is. Unfortunately, drugs with limited role. Of course, they have epigastric dyspepsia. You can use H2 receptor antagonist. You can use, the PPIs. You can use piezotifen for abdominal migraine. You can use peppermint oil in irritable bowel syndrome. Again, they are not very important. Just if they're having only a functional abdominal pain, these drugs are not necessarily effective. It just could be a placebo response. Diet, again, there is actually absolutely no role apart from, you can give a high fiber diet for a child with constipation. That's going to help. But yes, cognitive behavior therapy is useful in children with, who has got a significant improvement symptoms, with an associated somatic symptoms. Psychological therapy, you can consider definitely. Prognosis is a good thing. I tell you, this is a very important slide. I want you to remember that. Aptly the pioneer in chronic abdominal pain, nearly half of the children functional abdominal experience pain as adults. But one good thing is the studies which look at long-term follow-up, they advised 161 patients. They have found only 3 patients to have had some organic disease. Otherwise, all of them had continued to have only functional abdominal pain. Now, let me go to cases. Now I'm going to have more interactions. Okay. 7-year-old girl, abdominal pain for 6 months, variable appetite. That's it I want to say you. I want you to ask me what other history you want to know. You can ask me. I will tell you. What is one important history you have to
Stool
ask?
habits, sir.
Yes, thank you. Anything else?
Constipation.
Yes, anything else?
Weight gain or weight loss, sir?
Yes, thank you. I think yes,
Pain.
very good. That's very important. Anything else?
Does the pain wake the child from the sleep? And
Absolutely.
location of pain.
Very good. Anything else? Very good. You ask all the relevant questions. I'm very happy. And as Dr. Venkat mentioned, the very important is stool. Okay? Stool is a very important issue. Don't miss that one. You can see this is basically the one is circled one is basically lot of stools. As you can see, what you see in the rectum is a rectal impaction, basically. And what you see in the right hand, and the top of that is basically, again, fecal loading. So this child has got severe constipation, fecal impaction. So how do you manage this patient? How do you manage this patient? Very, very briefly. What do you do with the patient? You want to give lactulose? Yes? Anything else you want to...
Enema has to be given.
Why enema you want to give?
Peg disimpaction, sir.
Very good. So what is important is nowadays, if the child can tolerate orally polyethylene glycol, you can give in increasing doses and you can disimpact orally. It doesn't have to give an enema. If they don't, then you can go for it. But what basically you have to give a disimpaction regimen, a higher dose, followed by a maintenance dose. If you just start with the maintenance dose, the child will not respond. That's the message I want to give. So let us go to, I'm going to give a brief case scenarios and brief discussion so that you get a flavor of everything what I see. So 9-year-old child, upper abdominal pain, and then lasting for 4 months, occasional vomiting, no other symptoms. What do you want to do? Yes?
Upper GE endoscopy, sir.
Yes. Why you want to do that?
Retrosternal pain, sir.
Yes. Anything
Probably
else?
reflex esophagitis with the vomiting.
Yes, correct. So most likely this one is upper. Again, you want to know make sure there is no insignificant weight loss. All those things very important. Yes, this patient qualifies for upper GE endoscopy because the pain is going on for 4 months and it's 9 years. And usually when they come to me, they would have had multiple bursts of PPI. So I have no choice. I have to go and do that to see what's going on there. So basically features of reflex esophagitis and GRD. The reason I'm mentioning this child is, and I want to tell you 2 experiences that just the recent months actually. I had a teenage girl who is 14 years who had something like this going on for 1.5 years. She is 14 and she weighs 32 kilos. She has lost weight of 10 kilo from the preceding 1 year. She typically says she has a pain while lying down. And then she has to get up in the night and she has to vomit. But this patient was treated GRD, was given, multiple courses of antibiotics for pneumonia and was given anti-asthmatics. But then, if you have a symptom lasting more than 3 or 4 weeks after a PPA course in child more than 8 years or 6 years, you need to consider second opinion. This patient, when I did the endoscopy, this patient had a bit of a narrowing in the lower esophageal sphincter. but I was able to go through. But this is very unusual for me. So I did a contrast study. I was definitely able to see a narrowing at the lower esophageal sphincter. I did a manometry. This was an eclasia cardia type 2. There are 3 types. This type 2 very much amenable to pneumatic balloon dilatation. So in the next sitting, I went for a balloon dilatation of the lower GI sphincter. You know one thing? Usually they may need 2 or 3 sessions, but this girl had only 1 session. You won't believe this. The child improved remarkably well. In the next 1 year, from 32 kilo, child went up to 52 kilo. I told, just please stop eating now. I don't want to eat anymore. Because she had a voracious appetite. And the most important thing is she was able to sleep much better. And she was able to concentrate well in the school without sleeping. So what I am trying to say is, please don't miss that one. Please don't miss it. Another boy who was a 16-year-old boy was at the same symptoms have been treated. But this boy more had a recurrent pneumonia, and they was in a CT, they did a bronchiectasis, they were treating medicines for bronchiectasis. But then he was also having reflux symptoms. So I did upper endoscopy, I was withdrawing that very soon. When he come back, when I was coming back, I found a little bit of abnormal, communication near the thoracic inlet. I was thinking, this can't be normal. I went back again. I was seeing the same thing. I would have missed it if I just pulled it up fast. Then I asked the anesthetist, before I was going into that opening, because it can be risky. I asked to intubate the child, because usually don't have to intubate. As long as they give the mask ventilation, I can go to do the upper endoscopy. When they intubated, I just found the other end of the ET tube and that open. And I did the endoscopy. So it was very much confirmed. This is a tracheoesophageal, which is confirmed CT's finding. And then it's a 16-year-old boy who was having symptoms from 2 years or 3 years, whatever they could remember. And by God's grace, I was able to close this tracheoesophageal H-type fistula endoscopically. After 4 months, I'm going to report this case, in one of the literature, and then he's doing very well. What I'm trying to say is, when somebody is having symptoms not getting improved, the anti-asthmatics, reflux medications, and whatever the recurrent pneumonia, please do think about other. And he was also given ATD for 6 months. Nothing happened. I'm just telling all these things are possible. This is a child, you can see the lower rhythm, there is erosions there. You can see that one. This is a very significant erosive esophagus. You can see significant erythema. Case 3 is a 12-year-old boy with a lower abdominal pain for 3 months, and he's having intermittent diarrhea, intermittent mucus and blood in the stools. What other history you want to know?
Weight loss.
Correct. Very good. Anything else? Anything else?
Whether pain relieved by passing stools.
Absolutely. Absolutely. Very good. Very important. Yes. Anything else?
Extra abdominal manifestations.
Correct. Excellent. See, the worrying thing here is in this the history. What is the worrying thing here?
More than 3 months. Diarrhea intermittent.
Passing blood in stools, sir.
Yes. Blood in the stools, the worrying. Blood in the stools is worrying. It says there is an inflammation going on. The diarrhea is intermittent 2 months, lower abdominal pain 3 months. It could be IBS. But then there is a blood in the stool. There's a mucus also. So it is inflammatory bowel disease unless proved otherwise. So basically, he had a bit of a low hemoglobin, an increased ESR, CRP, and also sometimes if you do a CBC, if you have a thrombocytosis, is an indirect marker of inflammation. And also when you do this kind of IBD evaluation, they also need to look at the albumin. If they have a small intestinal involvement, they can have low albumin. It gives a clue for me. Okay, so then I did an upper gender. I will talk to you about that. It just confirmed Crohn's disease. You can see severe ulcerations, this cobblestoning appearance. You can see all those things. All those things is possible. This is another boy, similar findings. Okay, there was no weight loss. The first child I was having weight loss. This is the rectum. What do you see here? This is the rectum. Similar finding, but no weight loss. What do you call this? Is an ulcer, big ulcer in the rectum. What happened, though the term is called solitary rectal ulcer syndrome, it's not necessarily solitary. It could be multiple also. In these children, the important history you need to ask is history of chronic constipation. Or sometimes they put their finger into the rectum and evacuate the stools. It may cause it, but this is slightly different. This is what you call as solitary rectal syndrome. This boy had a normal colonoscopy. Otherwise, apart from this finding. So what is this? The same sort of finding. What is this?
Polyp.
What is it? Polyp, yes. So you can do a polypectomy. This is similar symptom. Another boy, this is an upper GI endoscopy. You don't find this much of polyps in the upper GI endoscopy. If I find upper GI endoscopy, polyps and also lower GI, particularly upper GI, what do you look for? What is the diagnosis? What do you, so what do you look for? What do you look for in an examination?
Hyperpigmentation of oral mucosa.
Yes. So this child has a Pediatric polyp. So sometimes what happens, if you have multiple polyp and colonoscopy, then I tell the child need an upper GI endoscopy also. Or if there is any perioral pigmentation, or what I buckle, or if I find, that the polyps recurrent, I may have an upper GI endoscopy. Or the child presenting only the blood and mucus, blood in the stools, no mucus, no constant symptoms, is likely to be polyp. Otherwise, I have to think about IBD. I need to do both endoscopy and colonoscopy. Otherwise, just for polyp, I don't have to do an upper GI endoscopy. Okay, this is case for 15-year-old girl, epigastric upper quadrant pain for 2 months, preceding viral prodrome, significantly icteric right hypochondriac pain. What do you think is going on? What do you think is going on? Okay, anyone?
Pancreatic.
Viral hepatitis, sir.
Likely hepatitis. Thank you. So basically, what you do is you look at both the direct and indirect fraction, and you look at hepatitis A versus IgM, which is positive. So this is viral hepatitis. What is one important investigation you will do in this patient?
Ceruloplasmin.
No. Okay, you are diagnosed with viral hepatitis. What is one important investigation you will do that? Okay, but you have IgM positive. Okay, anything else you do? You are diagnosed this is a viral hepatitis due to hepatitis A virus. Okay, very good. Anything else? Unless you
rule out dengue.
Sorry? Dengue, you can do that. But this is I'm telling you this is acute viral hepatitis due to hepatitis A virus. What else you will do? What else you will check? Whenever you have a child, any acute viral hepatitis. Sorry? Repeat. I didn't hear you. Repeat.
Any other extra hepatic manifestation should be looked for, sir?
Okay, but one important investigation which is going to decide whether you are going to keep this patient with you or to me is a prothrombin time INR. Prothrombin time INR is very important. If the child has a high prothrombin time more than 1.2, 1.5, you give a dose of vitamin K and repeat the prothrombin time after 12 hours. If the child is not improving, please refer to a specialist. This child may end up having a liver transplant. I'm just telling you, not necessarily they need a PhD care plus or minus liver transplantation. So don't give the patients if they're having a significantly, persistently high INR, not correcting with vitamin K. So I'm giving salient features for all the patients. Okay, 10-year-old boy, right upper quadrant pain for 2 months. This child is having belching and bloating. Bowel habits are normal. Other examinations unremarkable. What history you want? What do you think is going on?
Dyspepsia.
What is that? What's the likely issue?
Sorry?
GB coli. Yes. The previous case, more likely hepatitis, but this one has got a belching and bloating also. Has got a multiple gallstones, and then basically he needed cholelithiasis, basically lab cholecystectomy. Is there any other test you will do in this patient?
Anemia, peripheral smear.
Yeah.
Peripheral smear.
You look for a causes of hemolytic anemias, correct?
Yes.
Okay, very good. Thank you. And also the obese patient, please check the lipid profile, HbA1c, all those things also. Yes, very good. And serum amylase is also important. They have a significant abdominal pain. Just make sure the gallstone pancreatitis is not there. Also check a LFT. But very important thing is you look for causes of the cholelithiasis. This child, 11 years old, Dr. Venkat, I have 5 or 10 more minutes. Is that okay?
Yes, sir. Please go ahead, sir.
Yeah, because a lot of interesting cases. We started late actually. 11-year-old boy.
Yeah.
Recurrent episodes of abdominal pain. Few days each episode. Multiple hospitalization. Bowel habits normal. What do you think is going on in this patient?
Abdominal migraine, sir.
Very good. More common things.
Mesenteric adenitis.
Okay, but usually mesenteric adenitis does not need hospitalization. But this side is having significant vomiting and he needs to be admitted. Recurrent episode of abdominal pain.
Cyclical abdominal pain. What?
That is a possibility. Anything else? More common. Always the teaching goes like this. You think about common, then go to uncommon.
Gastric.
Okay, but they don't have to get admitted so many times. Significant vomiting.
DKA, sir.
That's also, Dr. Jali has also given a very good thing. Yes, that's also a possibility. Anything else?
Pancreatitis.
Jali, I want to go back. If there's a DKA, usually, even with one first episode, they will severe, but they will not go back like that. Anything else? You have not touched one organ so far. So far, I give.
Pancreatitis.
Yes.
Pancreatitis.
That's the clue. That's why I talk. That's why I get the answer. Okay, fine. So pancreatitis, recurrent acute pancreatitis can cause like that. Serum amylase, lipase, check it. Don't miss it. Do an ultrasound, bulky of pancreas. So what happens in chronic pancreatitis? What do you look for? What investigation do in chronic pancreatitis?
CT abdomen.
Sorry?
Blood sugar, sir.
CT abdomen and MRCP, sir.
Yeah, but that's very important. What happens to amylase and lipase?
Be elevated, sir.
No, it can be completely normal.
They may be normal.
That's the point I'm trying to make it. Chronic pancreatitis, if you have to have a history of recurrent pancreatitis, then you go for imaging findings. And sometimes they may have a diabetes, but imaging findings. Chronic pancreatitis, just don't ignore just because their amylase lipase is normal. They had a previous history of recurrent pancreatitis. So you need to think about that. That's very important. That's the point I want to make. So next trial is chronic abdominal pain, 2 months periumbilical, intermittent vomiting, 2 bilious vomiting, bowel pattern normal. What do you want to do?
Ultrasound Doppler, sir, to rule out malrotation.
Very good. That's it. No other thing. That's very important. Very important. Don't miss malrotation. I will tell you, if you miss a malrotation, if the case comes to me for medical legal examination, I will tell simply that you have missed it. Simple. Why I'm saying that is because bilious vomiting, you have to take it seriously. If you miss a malrotation, I tell you one basic thing. In UK, one of the important reasons for bowel transplantation is uncorrected malnutrition leading on to bowel gangrene, leading on to significant bowel restriction, ended up having intestinal failure associated liver disease, then our liver problem also. These children had ended up having liver and small bowel transplant. Never ever miss malnutrition. If you diagnose malnutrition, if you refer the surgeons correctly, the parents, will be indebted for you ever. So don't miss a malnutrition, intersusception, don't miss at all, please. Okay, simple. So 4-year-old girl, abdominal pain, because I tell you why. Malnutrition, don't think that they're just going to come with acute. They can just come like this only. I've diagnosed many patients with acute malnutrition like this. So how do you diagnose malnutrition?
Ultrasound Doppler.
Ultrasound, what it tells?
SMA, SMV axis altered.
Altered. One important thing is make sure it's done by the pediatric radiologist. Honestly, I'm telling you, adult radiologists will miss that. Okay, always go for a specific person. If you're convinced that person is saying no, then is worried, no problem. But after saying that, you have to do a contrast study also just to make sure it's fine. Case 8 is 14-year-old child with pain 1 year, bowel habits normal. 3 weeks ago had episode of acute abdomen, now better. What else you want to know? But definitely 3 weeks ago, this child had an episode of acute abdomen and now got better. Child was hospitalized. Child then got better. So what other history you want to say? Ask.
Partial torsion of ovary.
Sorry?
Torsion of
Somebody said, I read past history of?
partial torsion of ovaries.
That's very good point. Very, very good. I think, but unfortunately, this is a girl. Okay, fine. Tell me. Anyhow, that's good point. Yes.
Ovary only.
Ovary, yes. Good point. Very good point. Very good. Anything else? So, in the history taking, we start with presenting illness. We go for history of present illness. We go for past history. Under past history, what else you will ask for?
Mensuration history.
Sorry?
Mensuration history, sir.
Past, yes. And then anything else?
Blood and stools.
Past medical history. And what else you ask for?
Blood and stools, past history of blood and stools.
Plus drug history, medical history, drug history, what else? Sometimes patients don't tell you all these things. Unfortunately, they don't tell you. Past surgery. Ask for history of surgery. You'll be surprised. They tell us that no, that is done, that is finished. But it has got a relevance here because these children are, those who had a surgery in the abdomen are prone for adhesions also. Basically, these are the previous surgeries, adhesions leading to subacute obstruction, And that is the reason why childhood acute pain, when it got relieved, it got better. So you have to look for that also. 11-year-old boy who had a 4 months upper lower abdominal pain. Bowel habits are variable. There is no clear risk of constipation. Appetite is reduced. Weight loss is there. But bowel habits are very variable. Upper abdomen. Anything else you want to ask for here?
Oral ulcers and anal ulcers are tagged, sir.
Yes. Anything else?
Weight loss.
Yes. Yes. There is a significant weight loss in this boy. Yes. So what happened? This is slightly difficult for you. But I was looking at him. Usually I see fecal stools, fecal impaction that are usually in the left lower, left iliac fossa suprapubic. But then there was suddenly diffuse mass everywhere. Everywhere I was having it. So lymphoma. This is actually a lymphoma. This is actually a lymphoma. So what I'm trying to say is, yes, most often it's constipation, but not unfortunately 100% constipation. Sometimes you find these things also. I did a CT, he had got lymphoma. Okay, fine. Next child, autistic child, 8-year-old, reported by parents. 1 second. Reported by parents, very uncomfortable, holding his abdomen 10 weeks, intermittent vomiting. So what do you want to do? What's going on?
Any specific food preference, sir?
Sorry?
Any specific?
No, Dr. Parivadini say, what do you say? Repeat, Dr. Parivadini.
No, I didn't say anything, sir.
Oh, Dr. Solay Kumar, somebody? Yeah, please say, I just saw the name. Okay, anyway, please tell whoever said, tell me what it is.
Any specific food preference, sir?
Very good. That is nothing. Parents is fussy. Anything else?
History of Paika, sir.
Very good. Very, very good. Dr. Arvind, I don't know who has told that. History of Paika. What do you mean by Paika here? What is that?
Child, preponderance to a non-nutritive substance.
So like what? Like what? Why you ask this question here in this patient?
intermittent vomiting.
Also. So I tell you what, you were asked a good question. Yes. Basically, he was eating the coir in the carpet. The coir, he was pulling the coir and is eating it every day for a period of 2 months going on. Mummy says, yes, he used to eat this one. Basically, ultrasound found some bolus of, this coir, but they were unable to find what it is exactly. So I did the endoscopy. Basically, I find the big coir there. I tried to remove piecemeal, but unable to take everything because some of them got adherent to the stomach wall also. So I went in for a laparotomy, and basically it's bizarre. So the history is important. Autistic child, it's very difficult for the child to report the symptoms also. It's very difficult, but the parents are always, very, very clear. He's usually not like this. He's usually not like this. They say that you need to be careful about that. Okay, 5-year-old by chronic abdominal pain, left abdomen, history of 2 episodes of hematemesis melina, abdominal distress, splenomegaly. What do you think is going on here?
Portal hypertension.
Yes, very good. No, usually they don't have significant, they have vague pain. Very good, well done. So basically, what do you mean by portal hypertension? What's the common reason in our country for portal hypertension?
Extra hepatic portal vein.
So what do you look for in ultrasound?
Portal diameter.
Yeah, portal cavernoma. There will be a thrombus in the portal vein and the collaterals goes around that. So that is portal cavernoma and the splenomegaly. Usually liver function is usually normal. This basically extrahepatic portal venous obstruction. Did have a banding, endoscopic variceal ligation. And nowadays we don't do that much of sclerotherapy. We can, even in small children, I can put a smaller bands. It's possible unless very small child, which may find it difficult. Otherwise you do sclerotherapy. So that is it. Okay, that's the child. So 8-year-old child, abdominal pain 2 months, particularly after taking meals. Significant abdominal pain gradually increasing. So abdominal resistance gradually increasing. 1 year history. Pain 2 months after taking meals, 8-year-old.
Any blood in stools?
No. Very good question. No blood in stools.
Any other surgery before, sir?
No. Thank you. Very good question again.
Peptic ulcer.
Yeah, I think you are right. Ulcer in children is not that common compared to adults, but in older children, adolescents, we do see ulcers. Okay, but this one, I'll come to you that. Also, the abdominal distension. There's an abdominal distension. So what history is important? We talk about medical history, we talk about surgical history, drug history. Sorry. Always ask for history of trauma, especially for tummy. Is abdominal distension.
Blood
Yeah,
injury.
basically, it's a child with acute traumatic pancreatitis, pseudocyst of pancreas. The pancreas, the pseudocyst grows so big, it was obstructing the gastric outlet. And there was a transaction neck of pancreas at the duct. So basically what I did, nowadays, we pediatric gastroenterologists, I do this endoscopic ultrasound, I do a ERCP, then through all these things, we can do endoscopy, cystogastrostomy. The child became very well, no need for surgery, absolutely normal after 2 years, no issues at all. That's the stent I put in initially at the time of removing and then I took out this stent actually. The 14-year-old boy sticking an epigastric in 2 months, mainly after meals, decreased appetite. Otherwise, there is no distension here. This is a classical case of duodenal ulcer. You can see the ulcer, the D1 area. The second picture is ulcer actually, significant erosions. Okay, case for significant epigastric pain, 4 months, pain more after meals, decreased appetite, fullness of abdomen and retching. Fullness and abdomen and retching. That's an important thing. Basically, this child has similar findings the previous one, but it was going on for a longer time, had gone for a peptic stricture. And there's a duodenal narrowing, D1 and D2. And that is the reason he's having fullness of abdomen retching after the food. So what I did, I can even dilate the D1, D2 stricture with endoscopically. Previously, I used to refer them for a gastrojejunal bypass. Nowadays, with the balloon dilatation, we can do that. And they usually do well. If they don't do very well on 2 or 3 dilatation, then I refer for surgery. Okay, I just want to briefly mention about foreign bodies, nothing to do with this topic, but I'm telling you something important. Even coins, before 10 years, 15 years, you don't have a pediatric gastroenterologist. If somebody swallows a coin, you tell them wait for 7 days. I tell you practically, if your own child is there, will you wait for 7 days for the child to pass the stools, coin in the stool? You will not do that. You will go and seek opinions to see whether you can do an endoscopy. This child came to me at 7th or 10th day. Can you see the coin color? Can you see the significant gastritis, significant erythema? Why we have to wait? Just remove that. I will tell people, get the opinion and get it done. Tell the options to the parents. If they say better remove that. Don't give the options to them. Explain the risk and benefit. Okay, this is a child with foreign body. I'm just telling that if you want me to remove a foreign body, don't give banana, because banana actually is going to delay the anesthesia to give the anesthesia, and also it engulfs the coin. I cannot see the coin. I saw only the banana. I was flushing the banana, then I saw the coin, because I could see the coin in the X-ray just before the endoscopy. So I was looking on screen, this coin under the banana. I have to look at that. Okay. And this is a button battery. People say in stomach, don't worry. No, you have to worry also in the stomach. It may not be as emergency as endoscope, as esophagus. But if in the stomach, try to remove them in 24 hours. That can cause also significant erosion. You will be surprised. Children can swallow anything under the sun. This child has swallowed AA battery. And that's so, to summarize, chronic abdominal pain, just look at the characteristic of the pain, epigastric, isolated pain, or lower abdominal pain. Look at the red flag signs and symptoms. Organic or functional. Epigastric, periumbilical, lower abdomen. Associated symptom, dyspepsia, all those things, look at that. Look for altered bowel habits. Identify the possible cause, focus it, do the target investigation, then treat. So my take-home message, chronic abdominal pain is a very common problem in pediatrics. Sometimes in my clinic, even 50 to 75% may be chronic abdominal pain. For you, probably 10 to 25%. Important to identify the alarm signals. Structured approach is very, very important. Targeted approach, as I mentioned. Remember that functional disorder is a distinct entity. It is real, not malingering. Row 4 criteria is very, very useful. Please do make a positive diagnosis of functional disorders. As long as you rule out the organic problems, make sure there is no red flags. Think about triggers in psychological reasons. And then pharmacology in functional GI disease has got a limited role. Please do consider second opinions. Don't wait so long. Like I mentioned, the patient with eclampsia cardia, like I mentioned, the patient with tracheostomy fistula, don't wait so long. So many years goes by, their quality of life is affected. Management of function is time consuming. It needs a lot of experience, a lot of discussion with the family. And that's all the references. Thank you very much for the patient listening. I'm happy to take any questions. I like audiences when they interact. That's what I like it. Dr. Shaila wants to ask something.
How long to give PPI in cases of acidity disorder, sir? How long to give PPI?
Yeah, very good. Very, very good question, Dr. Venkat. Very good question. See, basically, if in older children more than 6 years, 8 years, is a typical epigastric retrostomal pain, yes, you are allowed as a pediatrician to give PPI for 3 to 4 weeks maximum. That should be an improvement in symptom by the end of that. There is no improvement in symptoms. Please do involve. In younger children, in children particularly less than 1 year, the recommendation from all the academic societies not to use PPIs unless there is an erosive esophagitis. How you know it's erosive esophagitis? Unless you do endoscopy, we will not know that. So if you want to use PPI in children less than 1 year, it's better that they get evaluated. You are allowed to use H2 receptor antagonist less than 1 year for again a period of 2 to 3 weeks. That's not a problem. But if you want to use a PPI, if there is no access to pediatric gastroenterologist, please do use, the optimal dose 2-3 weeks. Again, do not use it. If you ask me practically, yes. If you ask me scientifically, that is not correct. They need to be evaluated. Particularly, there's red flags like failure to thrive, significant vomiting. They need to see us soon. Yeah, thank you. Next one. Anything else?
What is the role of Rantac syrup ranitidine in pediatric age group, sir?
Very good. Dr. Maidri, yes, you can give Dr. Ranitidine, not a problem. Ranitidine, not a problem at all, because there were some concerns about this, one of these NMDA, whatever it is, there means that is not proven. That is also one brand, even that is USA has evaluated in detail. So Ranitidine is safe to use in children. I absolutely have no issues, but I do not use ranitidine for more than 3 weeks maximum, 4 weeks, not more than that. You all know that tachyphylaxis can happen. Use the right dose. An important thing is ranitidine's onset of action is a bit faster than the PPI. So yes, you can use ranitidine. Nothing wrong that unless there is a severe erosive esophagitis. Yes, then use it. No problem. PPI. Otherwise, yes, you can use it. But if you think, but PPI is a better acid suppressant compared to ranitidine. But a milder symptoms, if you want to try, nothing wrong with that.
Thank you, sir.
Regarding ranitidine, we always hesitant to use ranitidine because of the arrhythmia or conduction defect in the younger
No, sir. Very, very good question. I tell you one thing. As long as you are using the correct dose, please document whether in history of heart problem, chest problem. I always ask this question and give the correct dose. And try not to use concurrently with domperidone or anything which you prolong the QT intervals. This is what I do. And I see people, adult practices uses a lot of people with domstal. I never ever use any combination medicines. My only combination medicine is amoxicillin with clavulanic acid, cefepime, sulbactam. That's it. I do not use any combination antibiotics or combination medicines for that matter. And so in this context, I want to say, I do not even use this so-called OFLAM. This is orindrosol and metronidazole combination. This is very irrational combination. I will say that. I told even the manufacturer one day, they asked me, I told you should go and stop this product, go and do something. I will support you. I will support metronidazole separately. I will support even ofloxacin separately, but I cannot support this combination.
Sir, again, the combination drugs for GERD diseases, some of the general practitioners attempt to use this antiemetic along with drugs like Gaviscon, sir.
No, you can use Gaviscon in younger children, no problem at all. Especially if you don't want to use, the PPI, nothing wrong with that. Yes, in older children, you can use Gaviscon for 3 or 4 days. That's it, not more than that. It's long-term use of
combined with the domperidone.
No. What I'm saying is, if it is a gastroesophageal reflux disease, the drug of choice is PPI, then ranitidine. And any other preparation, domperidone can be used only if you suspect motility issues. Domperidone per se is not going to improve the reflux. That's for sure. I mean, acid issues. And second thing, Gaviscon, if somebody wants to use, yes, 3 days, 4 days enough. Long-term use of any sort of alginate preparation is not recommended.
So what about the incidental finding of mesenteric adenoitis?
Yes, I always have this question. Mesenteric adenoitis, if you have a lymph node diameter, short axis diameter more than 8 to 10 millimeter, look for where it is. Is it in above the superior mesenteric artery, the celiac axis or the superior mesenteric axis? Then you need to evaluate further. If it is the right iliac fossa, periumbilical, lower abdomen, I don't think you need to worry. But always ask for history of fever, weight loss, significant pain. Short history, mesenteric adenoitis, it's a positive diagnosis. If it is any other history, that especially if the node is in the retroperitoneum or the para-aortic, then they need further evaluation. Per se, mesenteric lymphadenopathy, you see lots and lots of ultrasound reports nowadays. For me, 10, 8, 9, I will say actually 9 out of 10 or even 10 out of 10, I do not even bother about it.
But the child have a
If at all you want to do 1, 2 or investigations, just do a complete blood count, do a peripheral smear. Complete blood count is normal, peripheral smear is normal. You tell them that I've done the basic investigations. Your child is gaining weight. Your child doesn't have other problems. Your child is going to recover in 3 days. The child doesn't recover in 3 days. Come back to me. Of severe fever, vomiting, please make sure you rule out appendicitis. Yeah.
Sorry, any food.
Sorry. Yeah, doctor. Yes.
The incidence of celiac disease in South Indian population.
என்ன சொன்னீங்க? டாக்டர் சொல்லுங்க.
Incidence of celiac disease in South Indian population. Sir.
A very good question. Very good question. I tell you one thing. Very important thing is I always quote this history. Always quote this particular case. I had a boy who was 8 years. 8 years he came to me. At 8 years, his weight was 12 kilo only. He has seen multiple hospitals within Chennai. He has gone multiple times. Everything investigation was done. Every investigation was done. He was even evaluated for cystic fibrosis. But he did not have a celiac serology done. He's a Tamil boy, Tamil ancestry, everything is Tamil. But I tell you, I told celiac serology is very high. I did the endoscopy. He had a Marsh 3 grade celiac disease. I tell like this, east or west, whether you come from Earth or Mars or Sun, if a child is coming to me with significant faltering growth, apart from all the investigations due, whether he is from Chennai or whatever it is, I always check celiac serology. If it is normal, I don't bother about it. If it is abnormal, I go for endoscopy. In our especially the weight, significant failure to thrive, you have to do an endoscopy anyhow to look for other malabsorption. Yes, it's not common in Tamils, but I tell you one important study from Vellore. Whether I don't know whether you all know that. South Indians have the same percentage of HLA, D, Q or DR2 genes as like North Indians. We are less affected because probably our exposure to gluten products is less. And again, in some pockets of Chennai, I have patients who are from Rajasthan who settled. So you also ask for history of the ancestry also. But having said that, as I quote this Tamil patient, I always look for celiac serology if there is significant failure to thrive or GI symptoms.
Thank you, sir.
Anything else? And as I told you, do
role of
and serum IgA. Yeah, sorry.
Role of pre and probiotics in chronic functional abdominal pain, sir.
No, I think if you ask me functional abdominal pain, simple answer, no, full stop. But if you ask for infantile colic, okay, infantile colic actually comes under functional abdominal pain. Whether you guys know it or in children less than 4 years, there are 7 types out there. One is colic, rumination, and infantile dyspepsia, constipation, diarrhea, etc. One of them is colic. In colic, exclusively, the study evidence is for exclusively breastfed babies. Studies are very clearly documented evidence with the Lactobacillus reuteri given for a period of 21 days. Again, this study was not found to have enough evidence in formula-fed children. But if they had breastfed, this is found to have evidence. That is one of the functional GI disorders where it's found to have evidence. As of now, until today, there is no definite role in IBS or functional constipation or functional abdominal pain.
So how common you see giardiasis as a cause of abdominal pain in children?
Very good. Really no. Sometimes I do endoscopy looking for H. pylori. My histopathologist report giardia. I get very excited. Okay, I could at least find something in the histopathology. The stool report is always negative for anything. When I see a stool routine, it's uniformly standard. It's cut and copy for me. I always think it's the same thing. I don't know whether even they're looking at the stools actually. I always think that they just copy and paste. I don't think they're really looking at stools. So I found I had at least 4 patients whom had nothing but apart from giardiasis on endoscopy actually. So I treated them with metronidazole 7 days, 10 days, they are fine. Well, I think if you have a patient having abdominal pain, bloating, dyspeptic symptoms, nothing wrong in giving a course of 5 to 7 days of standalone metronidazole, no ofloxacin metronidazole. Yes.
So adolescent girls with recurrent abdominal pain with the endoscopy finding of lax esophagus.
Oh, yeah, they could have reflex. Yes, as I told you, apart from the rectal abdomen, they have any significant symptom, well, they need, you can, because it's 10 years, you are allowed to give 3 or 4 weeks of PPI. See for improvement symptoms. The child improves, stop it. Stop it. Always give PPIs once daily in the morning, 30 minutes before breakfast. Don't give multiple doses. I don't like that at all. Okay, that's it. So if the child improves, it's fine. Not improving, they need evaluation.
Is there any
What about isolated?
Sorry.
Any role of antispasmodics when the
I like this question. You know why I like this question? Because I like some questions which I really people don't want to do things. Antispasmodics, don't give it, especially the child having altered bowel habits. Antispasmodic basically relieves the spasm and the constipation is going to get again. Don't just keep on using cyclopam. Don't keep on using ribavirin. You can use if you are very much pancreas. This is a colic pain. I hardly use cyclopam combinations. I hardly use antispasmodics. Use in teenage girls if they say something pain related to menstruation. Otherwise,
What is the best analgesic for pancreatitis?
Very good. To start with paracetamol. I tell you why. As long as you give 50 mg per kg per dose every 6 to 8 hours, it's a good. Then second step, you can go for tramadol. Again, tramadol, this is one.
Whether IV
coming. Okay, 1 mg per kg per dose. Again, maximum you have to give only 50 mg 8 hourly. IV, again, you go for paracetamol. If you don't improve, then you can go for tramadol. You could consider diclofenac along with PPI, but if they don't respond, usually they need morphine groups or fentanyl-like drugs.
So what about asymptomatic gallstones?
If it is one stone sitting in the fundus of the gallbladder, no other symptoms, just incidental finding, just you find it 1 month ago, you can wait and watch. The stone is more than 8 or more, multiple stones, particularly in the neck of the gallbladder, symptomatic, pain after meals, vomiting, and then jaundice plus or minus fever. Definitely child needs LFT at least and amylase and CBC. Think about removing that because they are at risk for cholangitis or cholelithiasis. They may go for pancreatitis. Yeah, carry on.
How to treat fissure in constipation, sir? How will you treat the fissure?
How will you treat what?
Fissure in nano in constipation.
Yeah, fissure can be a consequence of constipation or it could be a cause of constipation. So, because the child is having fissure, child is having painful defecation, because of that child is holding the stools, because of that the water gets absorbed in the colon, it becomes very hard, child finding difficult to pass stools, and again bleeding occurs. So the first priority is to make sure the child passes stools soft, make sure you give adequate dose of laxatives. You can give topical analgesics for 5 to 7 days, but tell them very clearly, I tell them like this, if I have a cut in my hand, I can put a plaster, I can keep rest. Unfortunately, if the bloody ulcer is in the anus, I can't give any rest. Every time the child has to pass stool, it irritates the anus. So make sure the stool is soft. Until I tell you to stop laxative, don't stop. Full stop. Yeah.
So
how will you treat rectal prolapse in pediatrics, sir?
Rectal prolapse? No, it's not very common. If you have a rectal prolapse, ask for history of constipation. Very, very important. And also think about cystic fibrosis. I had only one child who had cystic fibrosis, but that child did have other symptoms also. So otherwise, with rectal prolapse only, treat the constipation, treat how the child is. Keep on persisting, then you look for other reasons also.
So second line anti-elements other than albendazole, like mebendazole, piperazine, and praziquantel, sir. And for resistant worm infestations, like if they come back again and again, even with 2 courses of albendazole initially, how frequently can it be given, sir? And how about the safety profile, sir? And what to do in these children?
Very good, Dr. Shaim. I asked this question because I had one child who was given albendazole every 2 weeks for 8 months in duration, ended up having a liver function test deranged. So if you are going to go more than 3 or 4 days, please check a baseline liver function and check it again. Don't, because they can cause hepatotoxicity. But if you're going to give, sometimes, you can give albendazole with ivermectin preparations available nowadays. You can do that, or you can give parental pomade, depending upon what worms you find it. I had one child who had similar problems. Then when I did the colonoscopy, he had a nidus sitting in the rectum. I don't know, somehow and that was creating worms every few weeks. So what I did was I just flushed it, everything, and that made them better. But again, I'm saying that, if you are very sure, I tell you, you ask the parents to take a photo and show to you. Just see what it is. And try to take away the factors, the risk factors. What's the predisposing factor? Look into that. Treat the family. Make sure the child is not eating the soil. All those things you have to ask history.
For 6 months to 1 year old children, like in infants, if the mother complains of frank passage of worm and stools, can albendazole still be given, sir?
Well, I think the recommendation is more than 2 years, isn't it?
Yes, sir.
Isn't it? Yeah,
Is
but
there
you
any
can
role
give
of
something.
parental PAMVET less than 2 years, sir?
I
Can we
think
use that parental PAMVET?
if you are using it before, I think you can use it. If you don't have an alternative.
Okay.
But usually, I tell you, very unlikely in a 6-month-old child, unless the child is going to be put on the soil. That child even, very difficult, very unusual. A 6-month-old having worms in the stool. You have to ask why the child died. You have to find the reason for that.
Yes, sir. For complementary feeding, especially in a 10-month-old child or 11-month-old child, they complain of occasional passage of worm and stools, sir. In that situation, we can give right, sir? Albendazole can be safely given.
Yes. Or you can think what it is. Yeah, and then you can do it. Yes, nothing wrong with that. Yeah.
Okay, thank you.
1 to 2 years, we can give half the dose, isn't it, sir? 1 to 2 years.
Which albendazole?
Yes, sir, albendazole. 1 to 2
Well,
years of
scientifically, I cannot recommend. Isn't it? Scientifically, I cannot recommend. But you're allowed to use as long as you monitor. Think about, also look at the metronidazole coverage also. Metronidazole is a safe thing to use also.
Sir, role of empirical H. pylori eradication therapy in a child presenting with dyspepsia and upper GI kind of symptoms. And my next question is, in a setting, sir, where UG
let me finish the answer for this one. 100% no role. Full stop. You cannot give it. As I told you, even if I find a H. pylori on my endoscopy, unless there is an associated gastritis or a duodenitis or ulcer, I will not give even eradication therapy. It can be a bystander. Always ask for history of H. pylori infection or in the family or history of gastric cancer. They're the risk factors. You need to know that. Just like that empirical, please don't do that. Yeah.
Understood, sir. Sir, second part is UG scopy is done, ulcer is documented, but HP is not done in a resource limited kind of constraint setting. And what is the role of
very good question. But I tell you one thing, if you are doing endoscopy, if you are seeing some findings, you are supposed to take biopsies. There is no answer there is no shortcut for that. If you say that biopsy costs something, I tell like this. Well, you say that biopsy costs something, 2,000 rupees, 1,000, whatever it is. But you give some medicines, they'll come back to again. How many times they're visiting, the travel cost, everything matters. So if there's a finding, child needs biopsy. There's no H. pylori, no treatment, only PPI. There's also H. pylori, then you have to give triple eradication.
Thank you, sir.
Sir, again, this is H. pylori infection, sir. This is the urease positive and symptomatic. We have to eradicate H. pylori, otherwise they are precancerous conditions.
Yes, you have to give a good dose of
gastro. The guidelines is there, sir.
You have to do that. Yes. What I'm saying is, that's what I'm saying. As long as you have some evidence like urease or some biopsy, something like that. If just the biopsy is not, I'm not bothered about it. But
ground we cannot suppose to use.
Urease positive should be there. At least. That should be there. Some evidence should be there. You can give, no problem.
Sir, one more thing for the documentation purpose regarding the chronic abdominal.
Before I forget, in H. pylori gastritis, what we find is a significant nodular gastritis or duodenitis. That's another thing we find, not necessarily only ulcer. Yeah, carry on, sir. Jalil, sir.
Sir, this is again for the documentation. This is a very important topic. Nowadays we are not using the recurrent abdominal pain. That first slide itself you have put in. Now we have put a chronic abdominal pain.
Yeah.
For the documentation purpose, if the child comes with this, can we write chronic abdominal pain as a diagnosis?
You can definitely use chronic abdominal pain more than 2 months, no doubt about it. And you are also welcome to use, the chronic 3 types: functional, organic, and the psychogenic. You are even welcome to use functional dyspepsia, irritable bowel syndrome, functional abdominal pain, otherwise not otherwise specified. You are allowed to do that. Infantile colic, infantile rumination, all those things you are allowed to document as long as you looked at other side. Absolutely fine.
Again, you mentioned in the functional category and the organic category, the irritable bowel syndrome, that is IBS, you comes under the functional, and IBD under organic, sir.
Yes.
It is overlapping. How we can confidently write in it is IBS or IBD like that.
If the patient is having IBS, if there's associated red signals, alarm signals, this patient need evaluation for IBD, including upper GI endoscopy and ileocolonoscopy. If IBD is ruled out, you can very well say IBS. If there is no alarm signals, alarm signs, you can very well make a positive diagnosis of IBS, follow the child. If the child continues to do well, you can reassure or give the option of and further evaluation by the specialist.
Like the dermatologist, eczema patient comes eczema. This IBS is chronic.
Yes.
You can put it like that.
No, dermal eczema.
Eczema is a chronic illness, like that. Very often they visit the dermatologist. But that the IBS patient also, they visit the gastro people.
Yeah. The thing is, what is important is, you mentioned eczema. No, I just want to say that there's an eczema atopic dermatitis persistent for more than 2 months, 3 months with topical emollients, everything given properly for dermatologists. One need to think about cow's milk protein allergy. 30% of patients with intractable atopic dermatitis have underlying milk protein allergy. Yeah, carry on. Yeah, thank you. Dr. Venkat, it looks like over.
Sir, lactulose, laxitol, PEG. Your order of preference, sir.
Which is laxitol?
Lactulose, laxitol, PEG.
Laxitol, what it contains? Laxitol, what it contains?
Hydroxyl form of lactulose is lactitol.
I tell you, I have not used it. Full stop. I tell you. And what I use, the first choice is Dr. Noordin. You are there. Very good. The first choice is polyethylene glycol for all age group. For disinfection, higher dose 1.5 to even 2 grams. For maintenance, 0.8 to 1 gram per kilo. Younger children less than 1 year or 6 months, you find it difficult to treat with polyethylene glycol. Yes, you are very welcome to use lactulose in good dose and follow them. Otherwise, first choice is polyethylene glycol, then only lactulose.
Thank you, sir. Thank you.
Newborn constipation, what to do, sir?
Newborn constipation, what age you are talking about? Immediate or when?
Yes, sir, after 2 weeks, 1 month to 3 months period. Sir.
After 2 weeks, no delayed passage of meconium. The child is growing well. First, no delayed passage of meconium. Always in constipation children, look at their spine, look at their tone. That's very important. No tuft affair, no pigmentation, all those things. Look at that. And then a sacral dimple, don't need to worry as long as you can see the base of the dimple is fine. If the child tone is fine, child tone and spine normal, child is thriving, don't need to do anything. As long as child is having soft stool, exclusively breastfed child can pass 1 stool in 7 days or 7 stool in 1 day. As long as it's soft stool, it's fine. But with the hard stools, you are welcome to use lactulose, provided, you rule out, other things. Particularly, the distension should not be there. There shouldn't be any failure to thrive, and there shouldn't be delayed passage of meconium. Having said that, in Hirschsprung disease, 50% of the patients could have passed meconium normally within 24 hours. Just they pass stools within 24 hours does not mean you are ruling out Hirschsprung's completely.
Thank you, sir. Thank you.
It's a neonatal constipation. For me, newborn constipation.
And most important, sorry, you can check thyroid TSH, you can check it. T4, yeah.
Sodium bicosulfate role in infantile constipation, sir.
Yeah, very good. I think usually infantile they do very well with the lactulose or polyethylene glycol. Usually they don't need sodium picosulfate. If they need, please look for other reasons why the constipation is still not getting responsive. Please do involve get a second opinion, because if you're going to give sodium picosulfate, do so only sparingly, not regularly. And then if they need it regularly, you have to really find the reason for the constipation, particularly in younger patients.
Thank you, sir.
Thank you.
I think we can wind up the session, sir. Thank you
you.
so much, sir. Thank you. Many thanks. Sorry, I apologize. I have not introduced you properly, sir, at the beginning. Viswanathan, sir, I apologize for that. This is a maiden attempt for us, and we have to overcome few technical glitches, and hope we in the coming meetings will
That's
be able to
absolutely fine.
overcome that.
That's absolutely fine. I am happy that I am the maiden and the maiden. I am there. That's absolutely fine. No problem.
I'm very excited to have the stalwarts, the representatives of Tamil Nadu IAP to the central chapter, Dr. Jalil sir and Dr. Viswanathan sir. They are rocking, and we are witnessing their flurry of activities in the WhatsApp. They have been posting various messages which they are taking part, as well as messages from the central IAP as well. Many thanks for all the participants from various parts of Tamil Nadu. Really, it's a very useful session. Which sir has answered many questions which are of practical importance. Many thanks, sir. And we wish to have one more session with you in the future also.
We'll do that.
Thank
No
you,
problem.
sir. Thank you so much.
Sorry,
Sir. Thank you, sir.
you were asking for me few months. I couldn't do it earlier, and ultimately it happened. I'm happy with that. And also I thank the Vienna District Club, for both very active participation and also supporting me in my education also. Thank you. Bye-bye.
Thank you so much, sir, for the very informative lecture.
Thank you.
Thank you, Venkat sir and Nikhil, for organizing this. Thank you so much.
Thank you. Bye-bye.
Thank you, sir. Thank you, dear Venkat.
Bye, Vijay.
I'm Paraman.
Thank you. The Paramanji. Thank you for joining, Paramanji. Thank you so much. Thank you.
Thank you, sir.
Bye-bye.
Nikhil, you can close the meeting.
Okay, sir. Thank you.
Bye, Jali sir. நல்லா இருக்கீங்களா?